Thank you, Dr. Zimmer, for selecting me as the honored guest speaker and providing me the opportunity to choose my topic. I've watched your career over these years and noted that we have published a significant number of papers, and we've done this in a collaborative, interdisciplinary manner, which has worked for both of us. And I just want to thank you again publicly. And much of the work that we have been doing is in the Goodyear laboratory, and that has served all of us well. Before continuing my presentation, I'm going to borrow a quote from a very famous surgeon, anatomist of the date, William Hunter. And were I to place a man of proper talents on the most direct road for becoming truly great in this profession, I would choose a good practical anatomist and put him into a large hospital to attend the sick and dissect the dead. That said, I will provide the perspective of a surgical neuroanatomist as I approach looking at the curriculum currently in place at the University of Cincinnati, but in many other institutions. And that is, there's a decreased amount of lecturing and a decreased amount of contact of faculty with students. And I think that can be critical, because I believe that there is value in having interaction with faculty, listening to history, paying attention to history. There's much to be garnered from that. I've also spoken to members of the departments of neurosurgery, otolaryngology, radiology, neuroradiology, to appreciate that we're on the same page. We're all interested in some of these topics, shared topics, and I think the success that we've had in the laboratory and as a group is because of our interdisciplinary approach, a collaborative, collegial undertaking, and it proved to be successful, and I say that with a tincture of humility. I am a believer in heroes and heroines, individuals who serve to guide and assist people in finding a path for their career. And to that end, I've brought 3 books, historical references to individuals whom I have considered my heroes. The first book that I brought is probably the most important one for me, because it's a story about Thomas Willis and his activities and his import and impact on medicine in the 17th century. One of Thomas Willis's most famous presentations or monographs was The Anatomy of the Brain. And in this, it was in 1664 that it was first published, and subsequent publications were made. But in this publication, Willis described what now is known as the Circle of Willis, the connection of the vertebrals and the internal carotid arteries, which made a circle, and as I said, bears Willis's name to this date. The last book that I choose is about one of the Hunter brothers. I mentioned one of the Hunter brothers earlier. The Knife Man, is an extraordinary life and times of John Hunter, father of modern surgery. William Hunter arrived in London 10 years prior to his brother's arrival, John Hunter. And when they arrived, they both worked together, both Hunter brothers worked together, and were teaching anatomy. Wendy Moore, who wrote this book, and again I say it's a wonderful story about John Hunter in particular, and I think is something that surgeons might look at and read with great interest. I have a deep appreciation for art and the history of anatomy and embryology, especially that involving the carotid artery. Thomas Willis and his artist Christopher Wren described the segments of the internal carotid artery. And in that process, they identified 4 segments of the internal carotid artery. This was not the first description in the literature, nor it will be obviously the last description. Interestingly, Willis' monograph also has a clear, succinct description of the distal dural ring, at least 300 years in advance of our current understanding. In 1938, there was a significant paper by Eric Fisher describing 5 segments of the ICA and the impact of tumors or vascular lesions on the angiographic appearance of the vasculature. The article was written in German, and it seems to me clear that many people did not read the article because, in my mind, Fisher had no information or wasn't even interested in segments of the internal carotid artery. It was just a perchance observation that these came to other investigators, and they incorrectly identified them as segments. So I think there's a take-home message. If you're interested, do not read a book about a book, read the book. Because I think the failure here was running to publication without clearly looking at all the aspects of the internal carotid artery in this situation. We were very interested in the ICA in Cincinnati, and it was the focus of our attention, and was and remains the focus of our attention. And you see first the 1938 description by Fisher, then you go to Guido and Roten, and then followed by Lajournée. And there are others that I'm not including here because we're not creating a laundry list, but each of these was investigating the segmentation of the internal carotid artery. It certainly tweaked our interest as well, and we began to examine the internal the ICA, and we came up with a classification system that had 7 segments, and it was anterograde in flow, whereas Fisher's was not anterograde, it was retrograde. And that's a significant difference. So our example of 7 segments was it was introduced to the medical community, and I think was embraced by many in the medical community. The issue then was, I became aware of a French publication by Guy Lazorthes 35 years earlier. His schema is quite similar to ours. It's always a good idea to carefully review the literature before claiming your publication is the first report of. More often than not, you are not correct. And I have not followed my own advice. And for this I ask forgiveness. To study history opens our mind's eye to the context and evolution of ideas. We apply what we know and reimagine it from a different perspective, in this case, the other side of the sphenoid bone. My esteemed colleague, Paolo Capabianca, wrote an elegant essay about the lesson of anatomy. Opposite to what one thinks, the nature of anatomy is unpredictable. It changes with the perspective and direction of viewing a specific structure, the level of magnification, and possible anatomical variations of landmark reference points. Anatomical conundrums during surgery can humble the most talented surgeon. Endoscopic nasal surgery challenged our thinking about the ICA segments and propelled us to desire a shared nomenclature for both neuro and ENT surgeons that we published in 2014. Following our establishment of a 7-segment ICA from an external operative position, we decided to look at it from an endoscopic perspective and see if the terminology would stand. We could apply it to both ENT and neurosurgery, open versus endoscopic surgery, and we strongly believe that our system can bear the test and serve to orient both ENT and neurosurgery. Helen Sabula examined the issue of the variability of the ICA, and in her study of 20 cadaveric heads, 40 sides, right? she was able to document that there are actually 4 types of ICAs possible. The first 3 are bilateral. The 4th is a asymmetric ICA. But taken together, if you need to pay attention to the variability on a specific operative case, because to not do that will potentially put you in harm's way. Okay, this ongoing debate regarding the segmentation of the internal carotid artery must and will be pursued. There's interest, and technology has to be considered as well, because with technology there will be for sure advancements, and some of this will have to be reevaluated again. A lesson I've learned in my career is to be open to opportunity and good fortune from seemingly odd connections. This leads me to an interesting story about Dr. Oscar Batson. Dr. Frank Mayfield asked me to prepare a lecture on the venous anatomy of the vertebral column, a topic which I had little to no knowledge. I met Dr. Batson initially in the library. I was looking at his books and his works and finding out what Dr. Batson had done, how significant his work was. I thought I have to now invite him to Cincinnati to be a visiting professor. In June of 1976, Dr. Batson came to Cincinnati. With him, he brought what would turn out to be incredible historical material. The seminal papers that he wrote on the Batson's venous plexus were provided to me, and a cast of the cavernous sinus, which used his injection technique and corrosion technique. You can see the model here, and it's been in this jar for about 40 years. We talked about looking at the cavernous sinus, and we were doing studies already at histological level in cross-section and sagittal section, and we're well on our way. And I don't know that he ever realized how significant a contribution he made, not just to me personally, but to our program. In dealing with Dr. Parkinson and Dr. Batson, I tried to bring them together in a certain way, because what Dr. Parkinson had done was describe the rostral continuation of Batson's venous plexus. Dr. Parkinson coined the phrase anatomical jewel box to describe what he called a very delicate territory at the base of the skull. And it was a jewel box because it was so compact, but it also presented the great difficulty of how to access that area. As fortune would have it, the cast that Dr. Batson gave me was going to play a significant role in our activity within our laboratory in Cincinnati. We created a dissection guide to lead participants in these programs through dissecting of the cavernous sinus and surrounding region. The course was taught by a number of our faculty, Dr. Tu, Dr. Van Loveren, Dr. El Khalini, and I also participated. This was one of the first courses we gave that reached a national level. Early on, Vinko Delenk played an integral role in guiding us through surgery of the cavernous sinus. We subsequently published our paper in 1991. The arterial and venous anatomy is important for surgery, but understanding its variations is even more critical and requires a keen knowledge of embryology. We turned to Dorcas Paget, who was a medical illustrator and subsequently became a scientist. She worked at Johns Hopkins, and she worked closely with Walter Dandy. He commissioned Dorcas Paget to carry out studies and understand and appreciate the development of the arterial and venous systems and their functions and variations, which are quite important because, and it's true that the venous system is far more complicated than the arterial system, but together they're both a very difficult undertaking. Here I show one of the samples of Paget's work, and she's showing the presumptive cavernous sinus in development. This is a very early developing embryo. It's a rites of passage that each resident and fellow who comes to the Goodyear Laboratory must study these documents, these seminal works of Dorcas Paget. Because of our interest in the development of the cavernous sinus and surrounding region, surrounding anatomy, we decided to look at it in a very classic approach, doing histological specimens and cutting them on a microtome. And you can see an example of cross-section and sagittal section. And believe it or not, it's like building a house. You can take all of these and you can, to three-dimensionally, form a picture of what you're actually looking at. In 1992, Dr. Kawase was so highly interested in the cavernous sinus and its meningeal structures and how one could access routes into the cavernous sinus and return safely without doing harm. And he spent 5 months pursuing this on his own. And we had a technician who was working with us, and she also was a valuable asset to help Dr. Kawase put his material together. And in the end, he published a paper. It was accepted, and it probably will be a seminal paper on the meninges of the cavernous sinus region. Dr. Kawase's presence in our laboratory had multiple effects. It was a great addition to our program, a great addition to the resident and fellow education, and it forms a collaborative arrangement that's persisting still today. So you make friends and you pursue issues of science, and as you stay together, you amass more and more information. As I stand in this hallway under the watchful eye of my mentors, I offer that you remember the shoulders of the giants that helped you and your career and preserve their history. And in doing so, others will preserve our history. Jim Liu recently presented at our annual course with a message of walking the line of radicality versus functionality. He's not the first to offer this tempered guidance, but as I reach this age in my career, I consider the legacy and how our work will be remembered. I am most gratified to see our residents and fellows achieving success in building a skull-base surgery program, and I think they are ushering in the next generation of skull-base surgeons. Comparing the relative exposure of transcranial versus endoscopic, or in the benefit of combining transorbital and endoscopic approaches. It all starts in the cadaver lab. Build a training lab, take the time to teach surgical skills and decision making, and be sure to include the context of history. I'm not on social media, but I understand its usefulness as a tool. I fully support Dr. Graffio's thoughts on the importance of anatomy. I end my talk with a final quote. You will have to learn many tedious things, which you will forget the moment you have passed your final examination. But in anatomy, it is better to have learned and lost than to have never learned at all. Thank you. I appreciate your attention.